All right, welcome everyone to another one of KCS's free webinars. And the public service messenger today with us is Adam Brown, good friend for a lot of years. And Adam has had some significant experience with long COVID, so he is going to be taking us through knowledge that he's gained over the last few years with this very pertinent topic. Um, in terms of this webinar, this webinar is being recorded. So any of your friends that were unable to make it, it will be freely available on our website. We'll probably get it up by Wednesday next week. And if you'd like to go through the webinar again, freely available online, as well as any of the other webinars that we have provided over the last 3 or 4 years at this point. So without further ado, I'm going to introduce Adam, who's an experienced physiotherapist and co-founder of Cornerstone Physiotherapy. And he is also into a lot of training for himself. Another lifelong learner, clinical masters, is a fellow of the Canadian Academy of Administrative Physiotherapists, a credentialed Mackenzie Institute MDT therapist as well. Adam's also doing some research up at the University Health Network in Toronto and is investigating how to best help people suffering from this myriad of symptoms, long COVID. And one of Adam's primary interests is how medical professionals can leverage data from wearable technology to assist in terms of managing long COVID, metabolic and other forms of rehabilitation. So Adam, thanks a lot for joining us, and you can take it away. In terms of just guidelines before Adam gets going, if you have a question, feel free to take yourself off mute and ask Adam the question. He'd be more than happy to hear it. I'll be manning the chat, so that if you would like to ask a question via the chat, I promise that I will pass that on in as close to real time as I can. And we'll also be doing some Q&A at the end. All right, thank you very much. Go ahead, Adam.
All right, thanks, Rob, and thanks, Jack, for having me. I'm just going to share my screen, which may take a moment to get it right. 1 second. I've done a lot of virtual talks recently, and this one, trying to get all my screens sorted out is often the hardest part. Okay, so it looks like that worked. Are you guys looking at a slide that says long COVID rehabilitation?
Adam, looks good.
Amazing. All right, the hard part's over. Like Rob said, I'm Adam Brown, physiotherapist. I'm the founder of Cornerstone Physiotherapy. We have had a long COVID rehabilitation program since long COVID became a thing. Actually, it was born out of during the pandemic, when we were all sent home. Myself and a group of our staff started to work on what we could do to help people recover from acute COVID. And we were thinking a lot of sort of cardiovascular type stuff to just put some free education out into the world. And as we were working with people in the medical community on that, long COVID started to emerge. And so I took a role as a clinical research coordinator with the University Health Network. And since then, I've been participating in both CanCove, which is a trial that is now over, and Reclaim, which is a big national long COVID investigation taking place through UHN. Our program at Cornerstone is interdisciplinary, so it's PT-led. We have OT, psychotherapy, and dietitians involved. And it's been a really interesting process. We do it with telehealth. It's open to anyone. And we use wearable tech, which we'll touch on in this, but I'll try and keep it more about long COVID than the wearable tech if I can. Like Rob said, if there are any questions at all, please feel free to just speak up or to throw it in the chat. There aren't a lot of places that you're going to go to get in-depth long COVID information. There's a lot of misinformation out there. And so please take this opportunity. If there's something that you want to know, I want this to be your talk, not just what I happen to put on slides. So by way of a quick outline, I talk about like what is the definition of long COVID? How do we even begin to categorize people with this condition? We'll do a little overview of the pathophysiological theories that are leading at the moment. Talk about how do we undertake a rehab assessment, or what screening tools are available. And then we're going to talk a little bit about what clinical syndromes exist inside of the umbrella term long COVID. And that's an important point, that there are, long COVID shows up in a bunch of different ways, but there are a few syndromes that are quite common. And once you know them, you can pick them out. And once you pick them out, you can choose strategies to help people and pair the strategies to the syndrome and have lots of success. We'll talk a little bit about some of the lifestyle management approaches that are necessary for somebody struggling with long COVID. Talk about other disciplines that are necessary in the rehab process. I, of course, will talk a little bit about wearable tech just because I have to. And then hopefully we'll have some time for you guys to ask some questions as well. So what is long COVID? It was defined by the World Health Organization early on, and this is probably the definition that has endured the most. Ultimately, long COVID is a post-viral condition, much the same as other post-viral conditions that we've seen. After the SARS epidemic, we had post-viral conditions that popped up. It's got a wider symptom presentation than most other post-viral conditions, mostly due to how the virus enters the cell. We'll get into that a little bit later. This definition, it's exceptionally broad, and it's broad for a reason. Early in the pandemic and at various points, people could not access testing. And for that reason, we can't have a confirmed COVID case as part of the definition. So we're talking about people who have a probable or confirmed COVID infection. We're looking at them usually around 3 months from the onset of that infection, and they've had symptoms for 2 months. It's not explained by other alternative diagnoses. And, the common symptoms are fatigue, shortness of breath, cognitive dysfunction. But it's super important to remember that the actual breadth of symptoms is very, very wide. There are over 200 symptoms that have been documented. The problem tends to fluctuate, relapse and recur over time. And so you can imagine that casts a very wide net. And, just about anybody who has any symptoms that are fluctuating and relapsing over time can and doesn't have another diagnosis can be applied here. And so we just have to, as clinicians, have take a little extra time to ensure that we're ruling out other causes of their symptoms. And we've seen in the program, we've caught people who, were suspected of having long COVID and had totally other things happen, like early onset ALS and other pathologies. So why is this the case? 200 symptoms seems like a lot. One of the things that tends to drive some individuals to think that this is a psychologically mediated condition is the fact that we have symptoms that are so broad across so many systems in the body, and that is a little tough to get your head around one problem causing all of those issues. But largely it's because COVID-19 enters the cell through the ACE2 receptor, and ACE2 receptors are throughout our body. They're in our lungs, they're in our brain, they're in our heart, eyes, intestines, you name it, we have ACE2 receptors everywhere. And for that reason, long COVID can show up in a variety of different ways in different people. There are patterns, thankfully, and we'll get to those, and they're very identifiable once you've had the opportunity to work with them a little bit. So the mechanisms under investigation for long COVID, basically all of these mechanisms you see on the slide: viral persistence, persistent and chronic inflammation, immune dysregulation, endothelial dysfunction, metabolic dysfunction, and autonomic dysfunction. They're all true. And in fact, they're not even separate. They're not all true for all individuals, but most individuals have more than one of these things. Several are related to one another. So a good example of that is that metabolic dysfunction, meaning the ability for our cells, our mitochondria, to produce energy from substrate. When we have a reduced capacity to process energy substrate, we get energy surplus. So we get insulin resistance, we get increase in chronic inflammation, we get immune dysregulation. And so all of those things are kind of related to one another. And so different researchers have thrown up flags saying, hey, look, I looked at a group of people with long COVID and they all have metabolic dysfunction. And then somebody else says, well, they all have persistent inflammation. So, well, they're actually all related to one another in a variety of sort of ways. So the rehab assessment, this is how we go through a rehab assessment. We use a tool called the Yorkshire COVID-19 Rehabilitation Screening Tool. This is a tool that allows us to gather a lot of information about how they're doing now, how they were doing pre-COVID, and some details about their acute infection and if they were hospitalized and all those sorts of things. It's not a particularly good tool to score and then score again later to see change, but it's an excellent tool to get a good and detailed background and to see what that individual is really struggling with. We do a Mediterranean diet screening just to see the quality of their diet and to identify people who might need that intervention. Spoiler is that a lot of them do need that intervention. It becomes a pretty powerful tool for controlling symptoms. We use a MCAS screening tool. MCAS is mast cell activation syndrome. Talk a little bit about that in a moment. And DSQ short form, which helps us to identify a subtype or one of the syndromes within long COVID called MECFS, which we'll talk about in a moment. So we capture and grade all of those symptoms and get a good picture of what's going on with the individual. Ultimately, the purpose of this is to identify which subtypes or syndromes are dominant for this person, which ones are present, and then which ones are holding back their function. And once you understand the syndromes, you can identify those relatively easily. Just see that. So at this point, I'm going to just go into these syndromes for you because they really do make up much of what we do with long COVID. So MECFS is myalgic encephalomyelitis. It used to be called chronic fatigue syndrome, which is why the MECFS. This isn't a new condition. It's been around since before long COVID. And for a long time, we were questioning whether or not these two things were really different conditions or whether long COVID was giving people MECFS. I don't know that that question has been definitively answered just yet, but let's say that the Venn diagram looks a lot like a circle. They they are close enough together that from a rehab perspective, our strategies can be similar. And so if you want to learn a lot about long COVID, one way to do it is to do a deep dive on ME/CFS. ME/CFS is characterized by mitochondrial dysfunction. So the ability for our cells to produce energy from food substrates. And it's variable mitochondrial dysfunction. It's not just always there. It actually increases and decreases based on what the person has been doing, eating, different environmental factors. In terms of it's important to look at the history of ME/CFS as a rehab professional if you're going to be working with anybody who has long COVID. And so one of the most important parts of that history comes in the form of an intervention that was called graded exercise therapy. And so the idea behind graded exercise therapy was, and it was incorrect, I'll just put that out there, was that these people were deconditioned. And that what we really needed to do was to start them low and just give them exercise and bump up the intensity at regular intervals and not worry too much about the fact that they were having increased symptoms as they went. That approach made people significantly worse. And that's why in the presence of long COVID, there is risk that people are showing up to rehab providers and being given inappropriate exercise programs. Now, exercise has a place in long COVID rehab, but you need to understand the condition and tailor it very specifically. And quote unquote, exercise may not look a lot like exercise at first. I've had people doing things as simple as sitting up in bed in order to try and deal with the orthostatic stress for 5 minutes before they lie down again. That was their exercise. Now, as the condition progresses and they begin to improve and they recover, exercise starts to look a little bit more like exercise. But it has to be done with real surveillance on symptoms. And the wearable tech that we use allows us to surveil a bunch of other metrics as well. That is very helpful. Okay. ME/CFS is largely characterized by the presence of something called post-exertional malaise. What that means is that an individual can do some level of activity or be exposed to some level of stress, whether it's central nervous system stress or physical stress. And there may be a period of time where they feel just fine. And at the time, they may feel just fine. But then it's followed by an acute worsening of symptoms that patients call a crash. That crash can take place hours after, and it can take place up to 3 days after. And it can last for a day, or it can last for 3 weeks, depending on what you've done. During that period of time, their mitochondrial dysfunction, their ability to produce energy with their cells, is reduced even further. And so it's really important that when we identify that pattern of people crashing after activity, not immediately after, but some period of time after, that's really the hallmark of that ME/CFS syndrome. So, if you have patients who you suspect have long COVID or who are seeking care in the community for long COVID, be very wary of programs that put exercise out front and don't do it with a lot of surveillance against symptoms and titrate it to the patient's abilities, not how they feel when they're doing it, not how they feel after they do it, but how do they feel for 3 days after they do it. So that's an important safety consideration. The next clinical syndrome is POTS. POTS is postural orthostatic tachycardia syndrome. I'm sure many of you are familiar with POTS. It's a type of dysautonomia. The reason I put POTS and orthostatic intolerance together is that some of our patients with long COVID don't meet the diagnostic criteria for POTS, but they still have orthostatic intolerance. Their symptoms are still driven by being upright. They still have tachycardic episodes when they're upright that resolve when they're recumbent. And, you know, one of the trends that we've seen is that people will go to a physician and get, tested for POTS, and they'll say, you don't have POTS. You're fine at home. And the reality is that, they're 5 beats per minute below the threshold for POTS on a 10-minute stand test. And I mean, they clearly have dysfunction. That threshold that we'll talk about a little bit later with the 10-minute stand is it's relatively arbitrary. And so what you're looking for when you're dealing with somebody who may have this condition is somebody whose symptoms worsen when they're up on their feet for long periods of time, who have episodes of elevated heart rate simply from being upright that resolves when they become recumbent. Now, dysautonomia is fairly central to the condition, and not all dysautonomia is POTS. So the second most common form of dysautonomia is idiopathic sinus tachycardia. So that's people who have, tachycardic episodes periodically that are unrelated to them being upright or supine or what have you. And then the last subtype is mast cell activation syndrome. And so this is a condition that causes mast cells to release an inappropriate amount of chemical into the body. It causes allergic symptoms and a wide range of other symptoms like itchy skin, mucus buildup, tightened airways, wheezing, headaches, GI distress. It may be a cellular expression of dysautonomia, because these two things tend to come together. In fact, when you have a patient who has MCAS, one of the things that we've noticed in the program and that we're just passing on to the research community is that when they have a mast cell activation syndrome trigger, which is often a food, and they begin to get their symptoms, their POTS test will be positive. And then when that episode resolves, we can redo that POTS test and it may not be there. And so you can see how dysautonomia and MCAS are closely linked to one another. Anybody who has this syndrome, usually there's a trial of over-the-counter antihistamines can help quite a lot. A low histamine diet is also very helpful, but patients have a tendency to have a real difficult time following it. But referral to a dietitian in order to help identify any food triggers. Thing about histamine response to food is that everybody's a little bit different. We can't just go by the list of high histamine foods. For some people, that list will ring true, and for others, it'll be a little bit different. And so there's an elimination diet process to go through that tends to help. At this stage, just so that we're clear, are there any specific questions about these syndromes that people wanted to ask? They are, somewhat complex, and I just wanted to make sure that nobody was sort of feeling like I was glossing over those a little quickly. Where's that chat?
Nothing on the chat yet there.
All right,
Adam.
Sounds good. We'll move on. So, early in the development of our program at Cornerstone, our first step was only to take physicians as patients. And the reason was that they understood the risks and they understood enough about what was going on that we could experiment with them, and they were comfortable. Now that we've had time with the condition, we know that there are certain safety considerations when dealing with people with long COVID, but that it's largely a self-limiting condition. People with long COVID do have complications. Some of them have clotting disorders and that sort of thing, but they're relatively rare. Obviously, out in the community, the biggest one that we see where people are being, harmed is the people who have the ME/CFS subtype or syndrome of long COVID, which is they say about 70%. I would estimate that higher, but it's usually when a well-meaning clinician prescribes exercise and tends to make them worse. And, our careers as physiotherapists have taught us that, discomfort in exercise is often good, and, effort brings results. Not so much for the ME/CFS crowd. For POTS and dysautonomia, of course, there's risks of syncope, falls. It can develop into persistent tachycardia or atrial fibrillation, and so people should understand that. And then the biggest thing is really like ruling out other pathologies, other things that are going on that maybe aren't long COVID related. And so if tachycardia, like I said, IST or idiopathic sinus tachycardia is common, but if a patient has IST, meaning that they have tachycardic episodes, but they are not driven by being upright and relieved by being recumbent, then they should see a cardiologist, because there are other reasons for tachycardia. And also there are probably some pharma strategies for that individual that are important. Ensure that primary care rules out other causes. And if symptoms don't follow these established patterns of that post-exertional malaise, if the symptoms aren't driven by orthostatic stress, or you're not seeing any dietary triggers, be suspicious that something else might be going on, and just do the extra homework to ensure that they can screen for other issues. One of the strategies that we use with people with POTS is sodium supplementation in order to expand plasma blood volume. Be careful with that with people who have hypertension. Expanding blood volume when you already have hypertension obviously drives that up. And some medications that are commonly prescribed for POTS can make hypertension worse, one of them being midodrine. And then the other one that I want to put out there that it's relatively new to the long COVID research. What we're seeing now that people have had the condition for some time is an accelerated metabolic disease process. And so new infections, or not new infections, sorry, new cases of type 2 diabetes, fatty liver disease, otherwise healthy individuals with hypertension, those sorts of things. And it makes a lot of sense when you consider that, when you consider the drivers of metabolic disease. And then if we've taken the ability to process energy down, but we're still putting it in, it makes sense that we drive insulin insensitivity and metabolic disease. And so just be aware and encourage people to monitor those things with their primary care provider, and understand that the usual advice for metabolic disease is go out and exercise, you're deconditioned, that's not going to help these people. And so they might need a different approach. So syndrome-specific rehab strategies. So this is what we do. We identify the syndromes, and then we choose strategies on the basis of the dominant syndrome with the individual. So which syndrome or which symptom pattern is holding back their function the most, at the moment, and that's where we start. Okay, so that treatment, it has to be tailored to these syndromes and symptoms that that one patient has. This is why one size fits all does not work with these people. And group-based programs where we're simply educating with syndromes, it's good, but it's these are difficult things to action. And so don't be surprised if people have a very hard time with that. So we start with that most functionally limiting problem. A good example of that, and one that we see really often, is that a patient will come in and they have a positive 10-minute stand test, so they have POTS, and they have a history of post-exertional malaise, so they have that ME/CFS phenotype as well. They may not be experiencing the ME/CFS because the POTS is so bad that their physical activity is never high enough to crash. And so sometimes you as a clinician need to have that in the back of your mind, because if you pull a bunch of levers to make the POTS better and you don't educate the person on that, they're going to ramp their activity and crash. They're going to think that that crash is because of what you've been doing. So you have to see how these things interplay with one another, and fix one thing at a time, expecting the next syndrome to be the next limiting problem. So POTS strategies. There's a great paper by the Canadian Cardiovascular Society, Raj et al., 2020, that is a position paper on POTS. It's got everything in there. It's a beautiful paper, has a pharma section and all of the non-pharma strategies in there. I share it with patients all the time, but here are the highlights. Hydration strategy is super important. These people need to walk around with a water bottle in hand, loaded with salt, assuming no hypertension. And they're looking at 4 to 10 grams of salt a day, usually on the higher end. Usually people are getting symptom relief somewhere around 6 grams of salt, coupled with 3 liters of water. And so what that does is it just expands blood volume. Now, when people go to their primary care provider, they're often told these things, but they're not given a strategy to say, eat more salt, drink more water. Well, when someone actions that, they eat a bunch of salt at meals and they drink some water at periodic times through the day. Your kidneys work all day long. And believe me, if you're drinking 3 liters of water and 6 grams of salt, frequent trips to the bathroom. So what we need to do is to load the hydration and electrolyte solution in the morning, and we need to keep it going through the day. The idea is to expand blood volume and keep it expanded. And so we can't have this roller coaster where we jack it up and then we wait and they come down again, because that's going to wreak havoc on their symptoms. Waist high compression stockings. These are prescription strength, 30 to 40 milligrams of mercury, available through places like Shoppers Home Health, that sort of thing. They are custom. They're measured to fit. And they really work. Patients often, there's a bit of a breaking in period. They don't love them right away, especially on 42-degree heat days. They will probably opt to stay home and be recumbent rather than put those suckers on. But they're very helpful for people who have to work on their feet. Something that we have kind of coined orthostatic pacing, which basically means that we've looked at all of our testing of our POTS patients in our biometric data, and we can see where their heart rate really starts to take off and get away from them. And we will have them set a timer so that they need to get recumbent, or basically we usually recommend that they get flat on their back with their legs up on the wall in order to return blood flow to their brain, just inside that interval. And so that heart rate is never really skyrocketing or getting away from them. And then as they begin to get better, their orthostatic intolerance symptoms get better, then we'll allow them to go longer. They'll go maybe every hour and they'll spend 5 minutes recumbent. And so it's sort of the same idea as, if I go and walk up the CN Tower tomorrow morning, I'm going to be exhausted. Maybe I won't make it. If I do it one flight at a time and I wait 30 seconds on every landing, I'll make it no problem. And so it's just that sort of pacing principle. Smaller meals more frequently. The reason is that blood flow to the gut pulls blood flow away from the periphery and away from the brain, causes symptoms to worsen. Now, exercise is a key part of POTS rehab. It is important, though, in long COVID to understand the asterisks on exercise as it pertains to the ME/CFS side of the equation. And so all of the POTS protocols that you're going to pull offline will talk about exercise, and they'll start recumbent, and then they'll increase in intensity, and then they'll go upright, and they'll slowly increase in intensity. If you were to just follow a pre-COVID POTS protocol, the chances are you're going to crash people. So you've got to find the balance between those things and try and get people doing things that that are within their tolerable range. And understanding ME/CFS, the tolerable range is dynamic. They have to understand how to assess that on any given day, and try and do the POTS exercise strategies within the confines of that other syndrome.
Hey, Adam.
Yeah.
Just wondering your thoughts on the word exercise. And as physios, we have this idea that exercise is grabbing some weights and lifting them up. And
yeah, it's totally not in this case.
I wonder if we could just consider the substitute the word exercise with the word loading, and because in the sense that you're putting a load on systems, and that could be the orthostatic system, that could be the musculoskeletal system, and I think that one of the problems we face as physios is we think exercise. Oh, I got to get out the weights. I got to get out the TheraBand. I've got to. Whereas simply as you're talking,
yeah, unfortunately, I think a lot of us use loading that way too. When we think about like loading strategies and that sort of thing, I'll often say, activity instead of exercise. For my people who have ME/CFS, and this is, there's so many great things about the wearables that help. But what I'll do is I'll look at their data and I'll see what they're already capable. But then I'll take that and I'll use it in a POTS strategy. And so usually people are starting out by lying on the ground and maybe pedaling or pedaler with no resistance at all. Like if you can stand and walk around the block, then you can do that, right? And so then you're slowly titrating that activity up and monitoring symptoms and monitoring response. But I totally agree. In fact, the word exercise in the ME/CFS community is a little bit of a hot button. Like I'll often get a bit of a reaction from the word exercise, but then when they understand what I'm talking about, that changes. And so I do appreciate the point that exercise is going to look super different. When you are engaged in activity prescription, ensure that if you are changing something, you are only ever changing one modifiable variable at a time. So that it might be the duration, it might be the intensity, it might be the position, it might be the modality, but never change more than one thing at a time because it will represent too big of a jump. That last category in POTS strategies, HRV biofeedback, is something that we use for people. It's the device that continuously measures heart rate variability, and you can do a breathing exercise with it that allows you to balance your autonomic nervous system a little bit, essentially driving parasympathetic drive through your vagus nerve. It's an interesting process. There's lots of things that do this. You don't need a techie gadget to do it, breathing exercises do it. This is just like a biofeedback way of doing breathing exercises. Other approaches like mindfulness, non-sleep deep breaths, all of those are aimed at the same thing, that taking people's autonomic nervous system away from this hypersympathetic state back to a more balanced state. So it is important to note that the HRV, biofeedback, and exercise are the only two interventions on there that actually aim to help rehabilitate the problem. Everything else is managing the symptoms, right? And so one of those two really do kind of need to be a part of the process. Otherwise, we're just sort of managing symptoms. Although if you manage the symptoms well, then you can do a little bit more activity, and that is essentially quote unquote exercise. So ME/CFS strategies, this is where things get a little bit more complicated. We use activity budgets, and so we use wearables for those. And like on your Apple Watch, that would be a MoveCal budget, where we can modify the little red ring on your activity rings and ultimately give you a budget for the day if the person's trigger is volume of activity. Pacing as an intervention sounds, when you first hear about it as a rehab clinician or as a patient, it sounds simple. It's not simple at all. It's actually really quite challenging. You have to pace your activity within an activity, within a day, within a week, and you're pacing physical activity, cognitive activity, emotional stress, temperature. All of those things are feeding into how the patient is feeling. And so they just need to be aware of the things that are outside their control so they can pull levers that are inside their control. That requires a fair bit of coaching at first. Spoon theory is something that as you look into ME/CFS, you'll hear patients talking about it. It's essentially the bottom line is people say they have a certain number of spoons in a day. Maybe they've got 3 or 4 spoons to spend, like basically, and once they're out of spoons, that's it. It's just another way of kind of looking at pacing. We also use we use a lot of biometrics in ME/CFS. We use a max heart rate limit or notification, and that's pacing the intensity of activity rather than just the total volume. It has been suggested for people who have ME/CFS to use their resting heart rate from that day plus 15 beats per minute and try to stay below that, because for an individual with ME/CFS, that reasonably closely approximates their anaerobic threshold, which is where it gets a little bit confusing, but the anaerobic threshold isn't at all anaerobic. It's the point at which you move from using lipid as a substrate to carbohydrate as a substrate. It's perfectly aerobic, but we call it an anaerobic threshold. The challenge with that is that you don't have to do much for your heart rate to get up above 15. It's very difficult for people to stay below that level. And also, if they have any dysautonomia or POTS, it'll be impossible. And so for some of our people, we have to use a few different things to find the right balance for them. For POTS, so if they have POTS, we will use their standing heart rate plus 15. So we're accounting for that upright position. Now, it's not perfect, because when you have POTS and you're upright for 5 minutes, it climbs higher at 10, higher at 15. And so when we're fully accounting for it, but it does help. The other thing, thankfully, that happens when you pass that threshold into that sort of anaerobic zone is that you pass your respiratory threshold. So this is the point at which your body starts to produce more CO2, and your breathing has to change. And so we coach people on how to find or recognize that respiratory threshold and have them stay under that in order to try and prevent crashes. It's okay to go above it, but you should go above it for an appropriate amount of time and then come back. You can't live above it, if that makes sense. Just like you or I, who are healthy people, yes, we can access those high gears of energy production, but we can only do it for short periods of time, and then we need to come back into a relatively efficient system. Basically, for ME/CFS, that ability to produce ATP at the cell at the base level, the bottom of the pyramid, where we're creating 102 ATP per molecule of free fatty acid, is severely impaired. Well, the next best system creates 36, and then the next one creates like 2 or 4. And so there's a real deficit in our ability to produce energy. So this is where Jack's point comes in. When I talk about exercise on the ME/CFS slide, it is cautious symptom traded activity with surveillance. And so that's where we're trying to estimate that threshold, stay below it, and just spend a little bit of time there trying to make our ability to produce energy using that system a little bit better. So we're pulling exercise physiology concepts from, history of sort of endurance athletes and high performance, but bringing it down into an illness environment where obviously those things look completely different, but we know that the adaptations can be similar. That point at which an individual should be exercising, so just below their anaerobic threshold or below their respiratory threshold, if you will, it changes from day to day. And so a patient with this syndrome, if they've been well rested for a week, their anaerobic threshold will be here. And as long as they're staying under it, they'll be okay. If they go over it substantially that day and they experience post-exertional malaise, when they're experiencing post-exertional malaise, it'll drop. And so we see this from 2-day cardiopulmonary exercise testing studies. Believe it or not, people have brought people with ME/CFS into the lab and had them do VO2 max tests. So they do the VO2 max test. They have a lowered anaerobic threshold compared to age-matched and comorbidity-matched normals, but not dramatically lower. They bring them back the next day, and their anaerobic threshold is way, way down. And so what tends to happen with these people when they get in a really bad crash, they get into something that we call a PEM squeeze, or post-exertional malaise squeeze. So they spend a bit of time above their anaerobic threshold and they trigger PEM. Now, if they were to shut down completely and rest, that could be a relatively short crash. But what most of us would do is we get up and we try and do less. We look after ourselves, we do the things we need to do. And the problem is that the threshold is changed. Now it's here, and my version of doing less is here. Well, that means on day 3, my threshold's even lower. So it just gets squeezed down to the point where the crash lasts an inordinate amount of time. So for us, data interpretation, we're monitoring patient-entered symptom data, we're monitoring resting heart rate, we're monitoring heart rate variability for signs of stress or evidence that the activity that we've given them is being tolerated well or not. And so we're surveilling them on a variety of different fronts to ensure that we're not going to cause a crash. These people also benefit from HRV biofeedback because they almost universally have dysautonomia. And then the other part of it that is interesting is that they have a tendency to do well with blood glucose stabilization and dietary strategies, which now the research is starting to show that actually there may be some benefit to metformin, which is also a blood glucose stabilizing medication. So we've been doing this for a couple of years because our long COVID patients were saying to us, you know, if I have a carby meal or if I have something sugary, my symptoms just go nuts. And if I avoid it, it tends to be better. So we started to put continuous glucose monitors on people and help them to learn strategies to stabilize their blood glucose, and they do quite a bit better. Well, it makes perfect sense when you think about that's the input of the system. So if you're not overwhelming the system with fuel, and we're not spiking the blood glucose without an ability to draw it out using their muscles, their activity, their body's functions, then we get problems.
Adam,
Yeah.
in terms of MECFS, for the non-COVID related syndrome, blood tests are showing like elevated levels of cortisol, interleukin 12, and some of those things. And maybe I missed this at the beginning, but is there a role for blood testing to look at markers for helping to identify people suffering from this, or is this more of a symptom-based classification system?
Yeah, so there's no consistent blood biomarker from a diagnostic perspective. The only thing that's really definitively and objectively diagnostic would be the 2-day CPET. To see that, you know, it's not normal for an individual to have an anaerobic threshold drop by 60%. That's totally abnormal. And so on the second day. And so that is diagnostic. There has been some work done in the UK recently where they've sorted out the way to do the beginning of a CPET test. So just to basically discover the anaerobic threshold, but not continue on to the VO2 max part and all the, you know, the maximal exercise part. And to be able to show a drop on the second day without as much risk to the patient in terms of causing PEM and a crash. And so that drop of that anaerobic threshold occurs even when the patient doesn't necessarily report significant PEM. So, but you know, this is one of the big problems with long COVID is an invisible disease. We don't have a biomarker right now. And so there's a lot of patients out there that are just not being believed. You know, when your primary symptom is, you know, dizziness, fatigue, pain, headaches, it sounds like all of these conditions that historically the medical and rehab communities have kind of typecast people a little bit. And so it's important to understand that this is a very organic condition. It doesn't help that it tends to have some psych consequences. So new onset anxiety and depression because COVID impacts the brain. And so that tends to drive clinicians to use the anxiety and depression to explain the condition instead of using the condition to explain. And I want to be totally clear that it's the other way around. The condition drives the anxiety and depression.
Good. And that's always good. We talk about that with low back pain. Does low back pain make you depressed, or does depression put you at higher risk for low back pain?
Yeah, well, I as you know, I was an advanced practice low back pain therapist, and I used to always say to people like, yeah, I mean, depression and anxiety are a perfectly rational response to the long-term low back pain. It's often amazing to see how those scores change by like third or fourth visit. So dysautonomia. So for those of you, we need to go over autonomic nervous system, probably not. essentially fight or flight, sympathetic, rest and digest is parasympathetic. It's like the operating system of your body. It does everything that you don't consciously think about. So thermal regulation, digestion, blood pressure control, heart rate control, all those things. People with long COVID very commonly have dysautonomia. So their system has a tendency to tip toward the sympathetic side. So their resting heart rate may be elevated. They have a tendency to have like sweating, GI motility issues, things like that. So we do a few different things for this. We use something called that. This is, again, in the world of long COVID, things haven't been around long. You can't look far for things, so you kind of have to make them up yourself. So we use something called autonomic intervals, which basically means produce some kind of sympathetic stress based on, you know, your patient. Sometimes they're already there, but if you use a little bit of movement, a little bit of activity to get sympathetic stress, followed by 2 minutes recumbent rest with a parasympathetic focus and breathing exercise. So teaching that person to bring their nervous system from up here down and bring the heart rate down. You can get better at this. It's actually quite amazing. Heart rate based pacing using max heart rate notification. So that's just not letting that sympathetic side get way out of control. So when you see it happening, stopping, breathing exercise, maybe recumbent. Again, talking about a lot about HRV biofeedback. And some of the things that we use to quantify this, we'll monitor their symptoms, their resting heart rate, their HRV. So, you know, people with long COVID almost across the board come in with elevated resting heart rate and HRVs that are very, very low for their age-matched norms. And then another striking one is the 2-minute heart rate recovery. And so that's where you bring their heart rate to a safe for them, but elevated level. And then you get them resting recumbent and you get the difference in their heart rate from peak to 2 minutes. For you or I, that's a pretty steep drop. A good score on that might be 30 beats per minute, 40 beats per minute. And someone with long COVID who has dysautonomia and they're tipped toward the sympathetic side, it'll be a very slow recovery. So their heart rate stays elevated for an extended period of time. We use that measure to test and retest the difference over time. And another one that we watch is the percentage of sedentary time that their heart rate is over 100 beats per minute. And you can only do that if you have a specific wearable that is going to report it. But it's useful to see change over time in an individual patient. There's no metric out there to say it should be below a certain point. What we want to know is over time what's happening. And so that's where on the wearable, the accelerometer is saying that you are sedentary, you're not moving at all, but you're still tachycardic. How much of your day is spent there? And so we want to see change over time. Any questions about that? No. So mast cell activation syndrome strategies, antihistamines are a first line of defense. And many patients report improvement in their symptoms with a daily antihistamine. Even symptoms that you wouldn't think were MCAS related have a tendency to improve. The thing about long COVID is that the symptoms tend to move together. So we have people who surveil their symptoms, and even when they surveil all the symptoms separately and we graph them, they move together. So post-exertional malaise in the case of ME/CFS is a worsening of all their usual symptoms. It's not just one or the other, typically. So the dietitian is exceptionally important in this program for all the patients, but the MCAS patients especially, helping that person learn which foods are causing a high histamine response for them. And again, MCAS and dysautonomia are really closely linked to one another. And MCAS trigger can cause orthostatic intolerance temporarily. So then those are our syndromes, and those are some of the strategies, or at least a beginning view of the strategies that we might use for people who have those syndromes. And then there's the foundation of recovery that I don't think we talk about enough in rehab with our patients. So this is what I would call just good recovery hygiene. And so nutrition, you know, if you are already in a position of chronic disease and metabolic dysfunction, you need to have a good diet. You need to have a focus on whole foods, low inflammatory, low histamine, high protein diet. We can't have people cutting calories to try and lose weight when they're trying to recover from long COVID. If we don't have the available resources, the recovery isn't going to happen. But oftentimes patients will be there when they come to us because they're worried about the reduction in activity. Blood glucose management. We will sometimes use a continuous glucose monitor, but you don't need to. You can just look up all of the different ways that people manage blood glucose before metformin was a thing. You know, the type 2 diabetes environment used to use all sorts of different strategies that are really, really effective. And we begin to teach them all about those. And supplementation where appropriate. Our dietitian will go through with them to see, are they getting enough fiber? Are they getting enough other micronutrients? One of the problems that we know from the research base in long COVID is that people have gut dysbiosis, so their gut microbiome is impaired. And so we want their diet to be friendly to the gut and have plenty of fiber, which is essentially food for the gut microbiome. Hydration, even if they don't have POTS, a lot of us are walking around dehydrated. For a lot of us, the fatigue that we feel is a lack of water. And so you just can't get away with that if you're somebody who's living with long COVID. Sleep hygiene and support. So we've done a bit of a deep dive on that and are able to coach people through it. Those who have more challenging problems will get sleep studies. If they truly have insomnia, they might seek CBTI. But if you're not sleeping, you're not getting better. Some learning around activity recovery balance. And so understanding that when we create a stimulus that's meant to drive recovery, that we need recovery after, and that's where the magic happens. You know, those of us who have done kind of more advanced training fully understand that if you go to the gym, you're not building muscle in the gym, you're building muscle the next day. But these people need to understand that when we begin to do something, we can't just hammer away at it every day. We have to create activity recovery balance, and that in long COVID, that recovery piece takes longer. And so that's something that we've noticed from the biometrics that, you know, if somebody has a big day, does a bit of activity, maybe it's prescribed or maybe it's just in their life, they might have an elevated resting heart rate for 2 or 3 days before that comes back down. And so that should inform the cadence of your intervention and your pacing. You know, in bold, eliminating alcohol. One of the things that has been great about this program and having all the data that we have, we have hundreds of patients and big, deep data sets, is that we see things that it's difficult to see without a big data set of patients. And right across the board, people do not tolerate alcohol well who have long COVID. Even small amounts that wouldn't cause intoxication will cause a worsening of symptoms very, very commonly. And so trying to get people away from alcohol is important. Caffeine, and obviously recreational drugs as well. And then ensuring that you have psych support where appropriate. Chronic stress management is important. So I think these things are important for a lot more than long COVID, of course. I think they're applicable to almost every patient we have, but then we should be talking about them all the time. But they're particularly important in the presence of chronic disease. I think that any program needs to be interdisciplinary. It's been so helpful to us to have OT, psychotherapy, and dietetics. To have they have sort of deeper knowledge in some of these areas, and it's an important, particularly important for these people because they have a multi-system disease. The wearable tech. How are we doing? So, you know, before the first thing I ever say about wearable tech is it does require very clear understanding of the data of what you're measuring, what it is useful for and what it is not useful for, what's noise, and what is just inducing anxiety. And so wearable tech as it pertains to chronic disease and rehab needs to come with coaching and with focus on what we should be looking at, what we shouldn't be looking at. Don't be surprised if you go into this and a patient says, yeah, I'm not getting up, I'm not running up the stairs anymore because my heart rate elevates too much. Like, oh, it's not a bad thing, that's just normal. And so, you know, it is important to provide context wherever you can. The way we use wearable tech, it is predictive. So it means we're looking for trends that signal that their autonomic nervous system is not handling things well and that they're at risk for a crash. So we're looking for multi-day trends of increasing resting heart rate, declining HRV, or an increase in the percentage of time that they're tachycardic while sedentary. So we have a bunch of things that we're surveilling to see, are they on the edge? Do we need to pull back, or are they tolerating things well and we can move forward? And then we use it from a prescriptive standpoint. So I can give an active cal budget. I can give a max heart rate budget or ceiling. Later on in rehab, I might give less a budget and more a target. And when I do get to that symptom titrated activity, I can give an extremely specific exercise prescription. And if I want to move the needle a little bit, I can move it 5% if I want. Whereas if I'm just chatting with a patient, then I'm saying things like, yeah, I want you to try just a little bit harder. Well, that's probably going to be 30%, 20%. Whereas wearable tech allows me to create increments that are just a little bit safer with this condition. So this is an example of a data set from a patient that went through the program. You can see in red here, this is their daily lowest resting heart rate. You can see early on, there was a lot of swing in that number. And then as we went on, it began to stabilize and actually trended down. Their HRV was exceptionally low at the beginning and began to trend up. And then that all in the context of the bar graph, that's their active daily calories. So their activity over time ramping up. And so it's not linear. Like this looks like it's maybe 40 points, but it's actually quite a bit larger when you expand it. You know, if you zone in on any one section, you would see good days and bad days. You would see elevated resting heart rate and lower resting heart rate. But with coaching over time, you're able to increase their activity overall while keeping them safe and improving their metrics overall. So I will say that Cornerstone is expanding the program. We're throughout Ontario now. We're opening up Alberta, BC, Saskatchewan, and Nova Scotia. and expanding in Ontario. And so if people are really interested in this topic and want to consider working in it, then we're happy to chat. It is not like taking on a new area of MSK or a new area of neuro. If you're already a neurotherapist, it's like being an MSK and taking on neuro. It's a big leap, but it's super interesting. And I think it's one of the only opportunities that I've seen in the time of my career where you get to work on something that's emerging, that you get to see the signal before the research. And it's really interesting in that way. But at this point, I'd be happy to take any questions from anybody. And go from there.
Please go ahead, open up your mics. I'll be manning the chat and we'll pass on anything. I'll start with a question, Adam. Early on in the world of concussions, we were treating people who had HRV issues and a lot of pacing issues, a lot of cognitive issues. Do you see overlap between this and people with chronic
totally.
concussion issues?
Yeah, I mean, I think that the approach is applicable to much more than long COVID. In fact, we're kind of working on a bunch of that stuff in the background now that we've sort of built the platform for long COVID. We've realized that it has a bunch of applicability, and so concussion is one of those areas. To be able to understand biometrics along with symptoms and patient context, that all kind of comes together to be really powerful. And metabolic rehab, other chronic disease management.
Hey, Adam, I'll just follow up on the comment I made before and get your thoughts on. I used a term, you used a term that I really just I liked, and I'd like to hear it again. I think it had to do with titrated physical activity, along those terms, and I think that this is really an important point for us as we move forward in our profession, and it harkens back to Rob's point, whether we're managing concussion, whether we're managing cardiac disease, whether we're managing acute low back pain or long COVID, is this idea of moving from, well, just like more weights and this idea of specific titrated physical activity. Any comment you want to throw on and expand on that?
Yeah, I mean, Jack, I think that it flies in the face of protocols, put it that way. I think protocols don't work for a reason, and even in the eyes of, or in the context of an individual who isn't struggling with chronic disease, what you can do today is affected by a number of factors. It might be your sleep, your hydration, your emotional state, what you did yesterday, all of those things. And you know, in the context of low back pain, what is the best thing for you to do now? It is what's going to create a positive stimulus that you can tolerate. So we need to approximate your capability on that day. And that's what symptom and patient titrated approaches are all about. And it just kind of, the idea that we're going to create just this progressive overload over time and it's going to be linear just doesn't work out that way. And I think as rehab professionals, we need to begin to look at or think about some of those other things that happen outside the clinic that impact our program and what we should be doing with people on a day-to-day basis.
Great. Thank you very much. Appreciate that a lot.
All right, people, last chance for questions for Adam. Adam's included his email address in the chat. So if you want to follow up with him later, especially regarding his expansion of his program.
Yeah, or if you have patients anywhere that are looking for help, they're happy to work alongside, you know, their current team. Or if you're a therapist or no therapist who really wants to get into this area, we'd be happy to chat.
All right. Well, at this point, I'd like to take the opportunity to thank Adam for spending his time with us tonight. And Adam, we're going to be posting this session freely available on our website. So happy for you, happy for anyone who was on this session to refer people to have a listen and take away what they can. And we are always happy to get feedback on other sessions that you'd like to hear about, and we're happy to try to facilitate that. So, Adam, thank you very much for your time. Really appreciate
Thanks for
it.
having me, guys. It was a good time.
And for everyone else, look forward to us posting our next webinar, which will be coming up in the fall, and you guys will be receiving some information through our Monday Mover on that. So have a great summer. Take care.